this early on into the care. Cardiac dysfunction we touched on earlier, but I do think this is really an underestimated part of the early death for these patients. These, when I talked about the physiology of Reboa a few years ago at EVTM, we kind of referenced the very well documented cross-clamp data from the cardiothoracic and vascular worlds. And so there is a degree of cardiac dysfunction that happens, especially in zone 1, not so much at zone 3 at all. But some of our centers around the country are dealing with a much older patient population, and so they already have a pre-existing cardiac dysfunction that can worsen with the use of Reboa. But actually, even young, healthy individuals seem to be suffering this. And when I've looked at our practice on the SICU, sometimes when we have a really sick vascular patient that's come up, had some endovascular thing, and put a TTE probe on, you can see that cardiac dysfunction. And certainly, as we've alluded to, TEE, I think, in the perioperative and immediate postoperative phase, can be really beneficial to help guide our vasoactive therapy choice rather than just throwing everybody on Levophed. And also even consideration for mechanical circulatory cardiac support if needed in the right patient population in that early phase, just continuing that hyper-aggressive treatment. But finally, I think, the keeping care in silos is really contributing to the death of these patients. And so what do we typically do is that our pre-hospital teams hand off to the emergency department team, and then they leave. The emergency department team hands off to the operating room team, and then they leave. And the operating room team hands off to the ICU team, and then may or may not be present or involved in the care immediately afterwards. And so what happens is that nobody's really talking to each other, and they're all kind of in their own silos, thinking they've done a great job for this patient, when in reality, that may not be the case for a subset of these patients. Dr. Lawless keeps referring to these as the sickest patients in the hospital. And so why aren't we treating them in a different way? So I talked earlier about bypassing the emergency department for a subset of patients and going directly to the operating room. And so rather than having a game of telephone where you're hearing one thing from the paramedic crew that's lost somewhere in translation for the ED, there's a direct communication of the pre-hospital scene to the operating room crew. In these super complex patients, maybe having a second surgeon in with you to assist with the care and achieve earlier hemorrhage control might be something to consider. And then also just bringing the intensivist into the operating room might be something to consider as well. I used to do this quite commonly as a fellow here at Shock Trauma. When I was on the SICU, I used to go into the operating room and talk to the anesthesiologist and watch what the surgeons were doing. And because, with my intensivist hat on, I was thinking about what would happen in the next 12, 24 hours, as opposed to the immediate intraoperative phase that the anesthesiologist might be acutely concerned about. And certainly just with conversations there, we could kind of tailor therapy sometimes to be able to lead to some potentially improved outcomes down the line. So just thinking along those lines turns that traditional approach into a much more physiology and team-focused approach where everybody's really sharing a mental model for these really super sick patients. So just to summarize, remember, we fixed one problem and really just created another with these deaths that are now occurring on the ICU. Our focus needs to be not only on the anatomy, which we've been really looking at, but the real physiology of in the perioperative period, addressing the coagulopathy, the acidosis, the ischemia, as well as the cardiac dysfunction. And don't be afraid to phone a friend and break down those silos to provide care for these sickest patients in the hospital. Thank you very much.
Zaf, I have a question for you. If you could make any one of these changes, which one would you make?
I think better collaboration across the teams. I think it's inevitably easy. And, I had this conversation, several times when I was a fellow. It's like, where does your critical care start? And so it doesn't start like physically when you're in the ICU. Why are we waiting that long to provide nuanced critical care? If their intensivist is much more experienced in dealing with these patients, a lot of intensivists may also be anesthesiologists, but all anesthesiologists are not intensivists. And so they just might not have that mindset or approach. So why not just play together and provide that critical care at an earlier phase?
To paraphrase Tom Scalea, critical care is not a place.
Correct.
Yes, sir.
Zeph, I just wanted to congratulate you on an excellent talk.
Appreciate it.
And so coagulopathy, it's a funny thing that we've created with technology. Like Mother Nature, like engendered like hemostasis and thrombosis to get, like if you're running through the woods and you get bit by a wolf. I mean, that's what, and now we put people on ECMO. And we put people, we do crazy things that Mother Nature ever engendered or intended. And how do we reconcile that to manage coagulopathy for things that humans were never intended to do? And I would love your thoughts.
Yeah, it's a good question, and I think it kind of alludes a little bit to, we're saving patients now who would have died beforehand, right? We're just, but the problem I think is that we rush to have a solution to stop the bleeding, and so much like we use Reboa, and we keep applying the other. So we're advanced in one thing, but we fall behind in advancing the other aspects of the totality of care. And so our thinking kind of needs to change to, as fast as we do to bring these new technologies and toys to our practice, that how will this study it for sure, but then rapidly adopt those changes along with it. I was a fellow in 2013. That's really when we started doing Reboa and the true, but really this is now in the last couple of years is really when we're starting to talk more about the physiology, and that's just a very long gap for these kind of things to happen. So I think we need to look at ourselves at being able to find those problems and addressing them earlier.
Okay, any more questions? All right, thank you, sir.
Great, thank you.
I think we're up for a coffee break, if I'm not mistaken. Another minute or two.
We're going to start this session in another minute or two.
So
don't really have to give people a hard time with time. Because it's a low key situation.
Yeah. Oh, this is a great meeting. I've never been to it. I was really excited.
You know, it's funny. I realize now, you know, because I realize that like, something like that. Watching
Well, the whole COVID thing, especially in Florida, it's something.
Yep. That's what our guys do. Our guys
We're like,
so funny.
is that right?
So he was always a good guy.
Yeah, he's funny.
Always, yes, funny.
When I
Dry
first,
sense of humor.
so it's I wanted to do vascular just to be a better trauma surgeon, and so actually it was Tom Stalea that set me up there. He said,
Yeah.
because Joe McGinn was up there, who used to be his
Yeah.
resident, right? And so he was like, oh yeah, this is gonna be your new fellow. And so they hated me when I first got there because they didn't want to train trauma surgeons.
That's what we should.
Yeah.
I bet. All righty. So this will be our last session. Everybody knows Con. I'm Sheldon. Con's from here, via New York, sort of.
Yeah, a little bit.
This session is specialties and education. And our first speaker is going to be David McGreevy. And his topic is EVTM for specialists in training, growing the EVTM ST organization. Is David here?
He's
All right.
outside, yeah.
We jumped the gun on him. We got plenty of time, so no problem. His talk has arrived before he has. That's all right. All right, so we we're just saying you're going to be speaking about specialists in training.
Sorry, I
Dr.
thought it was in 15 minutes. Okay, well, thank you. So this is a topic that I'm really passionate about. So no conflicts of interest. So basically, I want to start off by saying that, residency programs and fellowship programs have been around for ages. But it is really in the last 20, 30 years that there's been a dramatic change to them. And it's a change that I think that we need to be really aware of. Because, as we all know, we're all here at this meeting, technological advancement within medicine has made a lot of these changes. So, for example, improved imaging. We now have more laparoscopic surgery, robotic surgery, endovascular surgery that's changing the way that we work. Also other aspects of day-to-day work. It's different in different places, obviously, but regulation of working hours is not just the same as before where residency programs called residency because you lived in the hospital. That's not the same in some countries nowadays. And also, people have this change of lifestyle. People that work in surgery maybe don't want to be working all the time. What we can see with, for example, when imaging was becoming better and better, CTs now allowed us to make more better diagnosis. So it meant that also we were now treating certain injuries with non-surgical management. That then, in its turn, meant that we were having less elective surgery and also acute surgery because of these instances. And meaning that the open surgery that was remaining actually meant that it was maybe more advanced cases and therefore certain types of injuries then or so on that required expertise. And for residents, therefore that is meaning that there's going to be less and less opportunities to actually, for example, perform a laparotomy. Another thing about, for example, Anna mentioned restriction of working hours. So there's, been studies showing that actually sleep deprivation obviously is, we're making poorer judgment, and therefore we need to regulate how much we work and when we work. And that has also been shown that then this is causing a reduced individual on-duty time, which is leading to reduction of open surgery that residents are being exposed to. It's also marginalizing these overnight hours where, in some ways, independence is gained. Because if you're working more on call, you will actually be exposed to maybe certain things that you will be able to take by yourself without having people around the table, trying to elbow you away. And this obviously then also, because we're reducing the amount of time that you're allowed to work, it means that institutions have to employ more residents because they need to be able to fill the programs and the rotas. And that means that you've got more competition, more residents, more competition of getting into open surgery. Also then the younger generation now, there's a changing of lifestyle. People, it's not as important to work all the time. More people want to have, spend more time at home with their families. And that is also then causing, for example, surgery as a whole, as a specialty, to have problems which is, becoming maybe a very demanding specialty, a very stressful specialty, and therefore people aren't maybe as attracted to it, and be more difficult to actually recruit residents, depending on where you're working, obviously. And also, if a residency program and the reputation is that you're not actually exposed to very much open surgery, you'll maybe spending more time in the ER, and you'd be doing more, as we say, babysitting. You're not actually doing what you want to be doing, is being in the operating room. Also, surgery is, in a medical profession in general, there's more and more women also than doctors and surgeons, which will also maybe make a difference is, for example, parental leave and people spending more time at home. So how do we fix this problem with trying to educate future surgeons, future endovascular surgeons, future EVTM enthusiasts? And I think that this is an area that's rapidly changing, and I think that it's the institutions that need to also be aware of it, and also in themselves change the way that they educate young surgeons to keep up with this. So what we need, what I believe that is firstly, you need a very fixed curriculum. You need to have a formalized fixed curriculum and a flexible curriculum, which is individualized. There'll be people that will, as we were saying, for example, not all trauma surgeons are the same, not all patients are the same, not all trainees are going to be the same. People will need different aspects, more time spending in different areas. We also need, we've been discussing yesterday, there was a huge discussion around, for example, these things with more simulators and how we're going to be able to educate residents in the future. And I really enjoyed listening to that discussion yesterday, and I agree basically with everything that's been said. We need to be able to use these high-tech areas, for example, that can really help us educate young surgeons. So both simulators, but also we need real tissue practice. We need to be able to use cadavers or animals, for example. So, for example, also workshops like the EVTM workshop that we do in Örebro, best course, for example, here. And also the important thing is that not residents don't go there just once. They need to go there several times, because as we were saying several times in this symposium over the last 2 days, doing something once is not going to teach you how to do it. You need to do it on a regular basis. So these residents need to attend these courses, these workshops more regularly to keep up. Sending residents to different courses, maybe buying simulators that they can practice on, for example, has a huge financial implication on how to train them. Also, for example, employing more residents to cover rotas is also going to have a financial implication. And I think that hospitals and administration really need to be aware of this and make sure that they put in the money that's required. Also, there's a lot of the private sector, the industry that's really fueling this advancement of these techniques and the driving endovascular surgery, for example, and maybe also the private companies should be maybe in some way helping with financing education of young surgeons. We also need to increase the collaboration between both also different hospitals and institutions, but also different societies. This advancement within healthcare is going to go at different paces in different places of the world. So, for example, in the US, also in different places in the US, there'll be different advancements. Maybe we need to do more collaboration, sending residents to different places in the world, because different people will gain from this in different ways. So coming from a very developed country or a place, you'll be able to maybe go to somewhere that's less developed, but then be able to be exposed to more open surgery and more on a regular basis, whereas their residents can come then to other places where you can maybe see more of high-tech, endovascular or simulated robotic surgery and so on. We also need to include our residents, I believe, more into these types of meetings. That's exactly why we've had this, for example, the resident session yesterday, where to try and include and get residents more active into types of discussions that are at these meetings. And that's why, for example, the last meeting, the Devon meeting, we had EVTM. We had a few more people that were presenting. This time we had 5, which is really great and really nice to see that more people are being engaged. We've also got the EVTM video archive, which is another way of learning different types of and keeping up to date with how to do certain procedures. And I think this is also in different institutions can do this in different ways. So, learning things from YouTube and actually, so for example, the EVTM video archives that we have, you can learn about how to place a catheter, how to even open procedures. We've got doing a laparotomy or dissecting the femoral artery. You can learn about that. And also we need trainee organizations. So the last EVTM meeting in Örebro in December, we decided we would start this EVTM ST. So ST is for specialists in training. And the idea is to try and advance this type of development. So one of the first things that we've done now is to start the EVTM ST case discussion webinars. So it's on a monthly basis, Zoom-based case discussion, where residents are the ones that are supposed to be discussing a case. So there's one resident that will present a case at each time. They'll also be bringing with them then an attending from their institution. The idea is the attending then will give a bit of background knowledge and be able to steer the discussion in the right direction. But it's the residents or the trainees that are ones that are supposed to be doing the discussing between them. And we've been doing this now for 6 months. We've had 6 meetings, really interesting topics. So far we've had 106 individual participants. So many of these are regularly coming back and enjoying the discussions that are there. It's growing more and more, and there's more and more people that are joining every time. It's from 22 different countries. People have been joining in, and from 5 different specialities. One of the things also that we're working on within EVTM ST is actually creating an EVTM course for trainees. So the idea is that we would have a 1-day meeting every maybe 2 months where experts, people who are, for example, in this room, will give certain talks and describe certain aspects. We'll have a fixed curriculum of things or topics that we need you need to learn. The idea is also that you can join basically at any time during the year. So you'll be able to hop in, and as long as then after a year of participating on every single topic throughout that year, at the end, then you'll get a form of EVTM certificate, which hopefully also will be CME credited. So you'll be able to use that as you wish. And we're also starting what we call is the EVTM section in JEVTM. So basically trying to get more residents and trainees involved in submitting articles there, but also involved in reviewing articles. So the idea is that articles submitted to the EVTM section will then be partly reviewed by a trainee. And you start off as a junior trainee after maybe doing, say, 3 to 4 articles over a year. You would advance to becoming more seen as a senior trainee. And then after a few years, you can then maybe join the editorial board. So it's a really good way of getting more people involved and learning how to do different aspects of the job that we do. So this is not a one-man job. The EVTST Council, there's 6 of us there from different places of the world, Sweden, Italy, and in Israel. And we're really happy if more people want to join. Anyone just send me an email if you want to participate in the EVTM ST case discussions, or if you want to get involved in the other way. So my email's at the bottom, and thank you very much, and I'm open for questions.
David, I noticed you brought your little one. So can we consider it? It's a boy, right?
It is a boy.
Can we consider him to be a very, very early trainee?
Maybe.
I feel like you might have violated his work hours. So I wanted to bring Conan to the conversation with you. So would you say, because we were having a conversation just now about, how, Tom here at Shock Trauma has been trying very hard to weave together the two specialties. And Conan was just saying to me that it's been a bit of a sine wave, right? So when he was a fellow, please correct me if I get this wrong, many folks, when he was a fellow here at Shock Trauma, regular trauma fellow, many folks were interested in vascular, and the last year,
it always goes in waves, which I think will always happen in any specialty. And I loved your talk. I think part of it, I have a question about, though. I agree with you in terms of simulation. Simulation has to play a bigger role. What are your thoughts on the simulations? I mean, when we were doing simulations for laparoscopy in general surgery, you can get really good at this very quickly because it's the same simulation over and over again. It doesn't always replicate the skills needed to do this in real life.
Well, there's simulations where, there's different types of simulation. I don't know what the ones, but I've, for example, used certain simulations where, obviously there's a whole bunch of things that can happen. So, if you do something wrong, you'll also, you'll start bleeding somewhere. You need to fix that. Obviously, if you've done it 100 times, there's going to be a certain amount of cases, for example, in one of these things. Yeah, but I think that still it's, that's something that can be, it will evolve and it will get better and better.
And then how do you create proficiencies in, say, endovascular or something like this? How do you create proficiencies to say that a resident is ready for a next graded step in their, and they're able to do this in a human?
I think the idea is not that trainees and residents should only be doing simulation, but because they're not getting as much exposure to open surgery or any other type of surgery, that would be, to be able to practice. Because, one of the things is, we've been discussing that as well, is that, we're not supposed to be doing certain procedures on patients, that they actually don't need just because we want to train the resident or the trainee. And I think this is a way to, for example, for them to practice these things at the side. But obviously they need to be exposed to the actual cases at the end anyway. Mm-hmm. But that's why you need to combine simulation, cadaver, and workshops. So you don't, not just one of them, but you need to do all of them, and you need to do them on a regular basis again and again.
Yeah, no, I think this is a fascinating topic. I have so many questions, but there's a question in the audience.
Yeah, I would make it more like a comment. So great talk, David. And I have been able to see you go from our intern to resident and now standing up there and doing great jobs. And this is a problem internationally. We are struggling with the same things in Europe and in Asia, and how to fix it. A couple of slides you had there that you went through, like the societies need to be more collaborative on this. The older generation of surgeons, those with white hair here, must take responsibility, because what I'm missing right now, you say there's like this year is vascular surgery that attracts people, next year is trauma. I think it has to do with mentorship. Who was your mentor? And I think that there are outliers on both sides. People, residents that don't want to put in those hours, and residents that want to put in those hours. But who is mentoring them? We are missing that, at least in the Europe. We have very, very few people that actually take care of those that want to do more. And right now in Europe, and this is something that some places in the United States have managed to do it differently. At USC, Greg is here. They have the warm lab that is extremely good for their trainees. But in Europe, we are talking about to sending people to South America for training, and we send many people to South Africa. But then we get another problem that once their residents come to us, they cannot learn the things that we learn them in Sweden because they don't have the laparoscopic in those hospitals. They don't have, definitely not the endovascular stuff. But the point I want to make of all of your slides here, I think the most important was that the societies need to start to talking to each other and see how we're going to improve our training and push this forward for everybody's benefit. I'm not, Dr. Scalia is not here. I hope when I'm 50 or 55, I'm not going to take those calls, in-house calls. Okay, so I want to train my residents and my junior faculty. So when I'm hitting that age, that if they're going to call me, that's going to be like once a month, not for every case I'm going to hospital. So we need to take this issue very seriously and try to get every society involved.
I think it's also not just that that you don't want to be called, but you need to remember that, you know, the guy sitting here that can, you know, you can do all the advanced endovascular stuff, but you can also do all the advanced open stuff. You know, in 50 years' time, none of you are going to be working. And who's going to be working? Well, it's going to be us. And we need to be able to do some of this stuff because, you know, yeah, sure, I can call you maybe, you know, maybe I don't call you as often, but in a few years' time, I can't call you at all. And people will be calling me, but I've never done it. So how am I supposed to do it? So that's, you know, this is going to be the problem in a few years. So I think that's what we really need to focus on.
One more question, then we'll stop this. But in terms of duty hour restrictions, now we're adding more on top of our trainees, not just clinical work. We're adding, you know, didactics, case presentations. We're adding simulation. We're adding cadaver labs. How do we reconcile this? There's only a finite number of hours that they can do things.
Sure. I mean, yeah. I mean, and that's why I think it's important that you have a curriculum of how, you know, you need to know what you need to be doing. And maybe, you know, I mean, it's different in different countries, how long, you know, how the system works. But maybe, you know, it's not going to be 5 years as a resident that you need to take. Maybe you need to have 7 years, or maybe you need to have more years to be able to give you enough time to actually become, you know, a specialist or, you know, so on. So, I mean, I think this is something that we really need to think about.
Perfect.
Thank you.
All right. So our next speaker is Maria Wickstrom. How do the formal requirements to become a trauma surgeon differ worldwide?
Well, once again, thank you for inviting me to speak today. And we move on directly. I have no disclosures, so we move on.
Yep.
I wanted to take a look at what it takes to become a trauma surgeon in different countries. So I looked back to see what the requirements there are to become a trauma surgeon in Europe, in South Africa, and the United States. What is the path to become a trauma surgeon, and what are the formal requirements, and with a special emphasis on REBOA skills. So in Europe, the European Society for Trauma and Emergency Surgery administrates the examination for trauma surgeons in Europe. And if we look at the curriculum and what it takes to take the exam, so the requirements to apply for the exam is to have a recommendation letter from 2 trauma surgeons. You also need to have a certificate of completion of completed training as a specialist in general surgery. You need a completed logbook for operations, and the ATLS and DTSC course to do the examination. And the exam itself is a written exam and an oral exam. And if you pass the written exam, you are allowed to continue with the oral examination, and then you will have the European trauma surgery certificate. But if we look more closely on the curriculum and the requirement, we can see that in the initial chapter, the assessment and damage control management chapter, that the requirements for REBOA skills is actually only that you need to have knowledge about the REBOA procedure. There are no formal requirements for operative REBOA skills to become a certified trauma surgeon in Europe. All right, so moving on to just have a quick look at the Swedish certification for trauma and emergency surgery. It's the same in Sweden, actually. We don't have any formal operative skills requirements to become a certified emergency and trauma surgeon in Sweden. We don't even have a written exam, but you have to do an application to the National Board for the Swedish Surgical Society for Trauma and Emergency Surgery. And you need to have completed some theoretical goals. You have some practical skills, your operative logbook. You have to pass some courses, and you have to have some professional skills, research requirements and leadership requirements, mass casualty requirements. But that's it. No operative requirements for REBOA procedure, no REBOA courses. Okay, how about South Africa? Well, the College of Surgeons of South Africa administer the examination for post-specialization in the subspecialty of trauma surgery in South Africa. And to take the examination, you need to have completed the general surgery training, of course. You need the ATLS, the STC, the FAST, and the mass casualty course. You also need a written report from head of department that you have completed at least 2 years of training in a busy level 1 trauma center, of which 9 months have to be in the ICU unit. And you need the operative portfolio with operative and diagnostic procedures. And then you are allowed to take the South African written and oral examination. It's 1 day, and you have to pass the written to continue to the oral exam. But if we look at the curriculum in South Africa, even in South Africa, there are no requirements for REBOA skills. How about the United States? And please correct me if I have misunderstood it or got something wrong here. But as far as I have understood, you have 2 years of fellowship in which the first year is surgical critical care, and you focus on surgical critical care courses, the ECG, bedside ECG. You're required to train in ECMO, CRRT, but also the REBOA, and there are requirements to take the BEST course. And the second year is the focus on trauma surgery and acute care surgery. And then you do the AAST examination. So putting this together, it seems like in Europe and South Africa, there are no formal requirements to have REBOA skills to become a trauma surgeon. But as far as I can see, in the United States, you need to take the BEST course and have the REBOA skills. So my question is, for the future, if Europe and South Africa should consider to adopt the BEST course in the similar manner as we did with the ATLS 25 years ago, when it was started in United States with the ATLS courses, and now it's a global knowledge that's basic for every trauma surgeon. So it's a question to the audience and something to think about for the future. And I spent 8 months in South Africa, and certainly there are a lot of patients that would definitely benefit from REBOAS. But since they are so used to do the open thoracotomy and they do it quickly, I think perhaps that is an issue that the need for REBOA might not, they don't feel that they have the same need for REBOA. It's also, of course, a cost, a matter of economy and the cost of a REBOA, of course. Thank you.
Hi, Maria. Thank you. Great talk. And I would like to, I think REBOA is overinflated in the world. I would like to say, I would like to take it a further step. And we have the founders of the best course here, of course, Dr. Brenner, the colleagues. I would take it further on. I think what people dealing with acute surgery and trauma has to have best trauma surgical knowledge, or EVTM. We're a bit competing here, which is best. Of course, EVTM is best. I'm joking. I'm joking. It doesn't matter what, but I think you have to take it a further step, not to think about this balloon. Think about skills to help the patient in hemodynamic instability, for example, bleeding, for example, trauma, for example, the balloon or other issues, and to bring it into the curriculum. And I think now the States is much ahead in this, because you have a requirement. We just did the best course in Israel, for example, which was great because also it's accredited. You know, it was not such a difficult thing to do. We got all the support from the Americans. You have the accreditation, you have the documents. It's very simple. And I think people were happy with it. I'm not sure in Europe, maybe the best course or EVTM or whatever, but something to increase the knowledge. And I would say the society, I presume, and the vice president is in front of me, the EVTM Society will support any initiative in this, I suppose.
So, Tal, just before, just to clarify, and it's confusing. So in the United States, there's kind of two ways to become a trauma surgeon. So there is what you correctly identified is the pathway, in a sense, through the AAST and a 2-year fellowship. And I'm learning from you that it sounds like incorporated into that curriculum is now the best course. But the average way, the most common way, the most common fellowship that someone becomes a trauma surgeon in the United States is through a 1-year critical care ACGME fellowship. And so far as I know, and Con and I were just talking, they have not added to that the REBOA requirement. But it is, you know, just like so many things in the States, it is confusing.
The board certification, as far as I remember, it's been a while since I did it, is in surgical critical care by the American Board of Surgery. The second year is optional.
I see that Chuck and Dr. Brenner has a comment about this, though. I see.
Chuck, go ahead.
Chuck, sure.
You speak about implementation of REBOA in a difficult environment like South Africa, where they do ED thoracotomy, and I just rise to say that I am thankful for Dr. Moore, having been a zealot of ED thoracotomy, to be willing to consider options. And you need to partner with somebody young that wants to evolve and try something new that might be good for a patient, with someone with influence like Tom Scalia or Gene Moore, who will basically say change is important and there might be applications. So I think the people in South Africa could learn from us.
Just a comment. I think we should look at REBOA not as I mean, we all know that it's not a procedure that we will perform every day on an everyday basis. So that's not what I mean. But I mean, I think we should look at it as the thoracotomy. As a trauma surgeon, you have to know how to do it, because the day the patient arrives that will benefit, you must be prepared. And I think we should look at it in the same way with the REBOA skills and train for it, so we are prepared when that patient arrives. Okay, sorry.
No problem. Thank you. I just want to clarify, there's no strict requirement that any trainee program takes the best course. I think the only people who require the best course are specific institutions who, when you apply to get your credentials to do RIBOA, you check off a box that says I took the best course, or E-stars, or any of the other standardized courses out there. So as far as I know, there's no actual training requirement for it. As far as going out, making it more international, we're trying, we're progressing. I'm incredibly grateful to the support that I've had from the COT to be able to do this, because without them, none of this would be possible. So the easiest way for education dissemination, just like we've seen in ATLS, is through the COT. But other programs like EVTM and E-stars, those are still great educational opportunities, and it just depends which specific one someone wants to adopt, but they're certainly out there. Thank you.
I thought I'd speak on behalf of South Africa, since I am representing them. So I think that there's two factors here. The first is that we're very resource limited. So all of our trauma surgeons, almost all of our trauma surgeons, have done training in RIBOA. We don't have RIBOA access. And that's a big problem, especially in our state hospitals, which means we cannot place a RIBOA because we don't have the catheters. So that's been a problem for the last couple of years, and we've been trying to get them back in. We were using RIBOA a lot more actively, and while we're very good at ER thoracotomies, and we do many of them, we are well aware that there's definitely a place for RIBOA, and we would very much like to incorporate that into our system, but we don't have capacity for that. So that's one of the issues. Obviously, training in it is important, but you also have to be able to use it then after you train. So we are sort of trying to engage with the industry, but that's one of the issues. Sure, we're very into and open to education and to learning and to getting new courses. I've chatted to Todd, and I think that's something we're definitely interested in. So anyone who's keen, I'm definitely keen on our side. The last thing I wanted to say was related to you spent, I don't remember you.
Only 8 months.
Okay, you
So
spent
nothing.
time in South Africa. So I'm running from Baragwanath's side, the Visiting Doctors Program, and we have lots of Europeans coming to learn with us and getting a lot of surgical experience, which I'm sure you did too. What's not happening is the opposite. So we're not getting to go to developed countries and learning the skills that you have to offer us. And I think that's where we're losing the benefit. Is so we're very happy. We have lots of people coming through, training with us for many months, getting lots and lots of open experience. And then we're not getting to go to Sweden and learning, endovascular. And I think that would be really what should happen. We should have a partnership that works both ways.
Yes. Can I just comment on that? I think we have a good example. The boss of the unit in South Africa I visited, he spent some months at Gothenburg Hospital, and he learned to do the rib plating procedure, which he took back home to Pietermaritzburg, and is performing now in Ngwalesane, where he is now. So that's one skill that we could actually learn as South African doctor. So I think there might be procedures that we could exchange. So that's a great idea, and I think we should try to develop that more.
Okay.
So just a brief comment. I would like to share the Brazilian point of view. So there, the trauma surgery is not yet considered a specialty. It's for a while, it's a subspecialty of the general surgery. And we are just about to have our first board certificate. The first group was formed by general surgeons who proved they had experience in trauma, and the society was born that way. And now the society is giving the opportunity to fellows who did 1 year in trauma surgery training to be certified by a written test. So that's what's happening in my country now. Thanks.
So I have one question then. With such variability around the world in terms of training paradigms for trauma surgery, and so many experts that are saving lives everywhere in this world doing trauma surgery in the way they were trained, is there a reason to standardize anything?
No, I don't think we should standardize it, but I think in countries where you can expect patient to need RIBOA, you should have the skills for it, and it should be. And I think if it's a requirement, you will need to provide the training for the surgeons. So I think it's good if it's under a requirement. It puts a pressure on the hospitals to provide education.
I think we're about to get the Italian perspective.
No, it's only short comment from the European Society of Interventional Radiologists, because we have also a board like this to get the certificate to do interventional procedures, of course. And of course, for us is maybe it should be easier to get an vascular access and to put the balloon, which whatever the kind of balloon. But RIBOA is not mentioned. So we don't have the basis to put the RIBOA, to inflate it, where to put the RIBOA, and for many times nothing about that. So if we have to do this during our practice, we need the help of a surgeon, we need the help of someone that knows all these things, because in our is not required. So that's why I think that it's very important to share our knowledge, our skills, because of I don't know. For me, it's easier to get a vascular access even if there is no pulse, for example, because it's a thing that I do every day. But now I know how to put the RIBOA, where to deploy, and how to inflate or deflate, but only with my practice and with my cooperation with surgeons, with anesthesiologists. And so that's why I think it's important to do course and to involve in the course everybody, surgeons, anesthesiologists, IR, whatever can share the skills.
Comment, question?
Yeah, sure. Quick comment from Japanese point of view. In my opinion, to that question is the best course is absolutely excellent course, but trauma systems such as the number of trauma surgeons, the availability of the endovascular embolization, and the availability of the CT scan and availability of the hybrid ER or differs from country to country. So we need to adapt the best course or something else to our country. And we need to learn the same thing globally, but we need to act locally. So probably we can adjust anything into our local. So, and for example, when it comes to RIBOA, the catheter differs from, we can use the same, but for example, we cannot use the PriTime or Cobra OS, unfortunately. So we need to adjust, but we need to share the knowledge and to share the experience in such EVTM or other conference.
Yeah, I agree with you. So organization like EVTM is the key to much of what we've been discussing here. And I think we should thank Dr. Wickstrom in that here. Thank you.
Thank you.
And our next speaker needs no introduction. How to set up a multidisciplinary RIBOA program, and that's Megan Brenner, Dr. Brenner.
All right, thank you so much for being here, the very last session of the day. We really appreciate you guys sticking around. So, all right, I'm going to talk briefly what I promised Sheldon earlier that I would chat about. These are the following, my disclosures. So when it comes to RIBOA and trauma, I'm not going to spend too much time on it, but just a couple of must-reads. These are some articles that have been published and literally take you step by step how to implement and adopt a RIBOA program in your institution. There's some that talk about basically risk falls, potential complications that can occur with literally each step of RIBOA and how to mitigate and reduce those complications. Here's another one from our colleagues in Brazil who've also published on the same topics. This statement has been brought up in this conference earlier, but in terms of how long the balloon should be up, this is where the numbers come from. These are just goals. This is what we should aspire to, even though it doesn't happen with every single case. But at zone 1, where you try and have the balloon occlusion within 15 minutes and expeditiously going to definitive hemorrhage procedure. And then greater than 30 minutes, not only do we know from the vascular surgery literature, but also from trauma, that it's associated with increased ischemic complications and mortality. And then for zone 3, those of you who have used it for zone 3 know that we can get away with a lot longer occlusion at zone 3, but the target is 30 to 60 minutes. Translation for all of this is get your resources in order rapidly. So switching gears, and I'm going to just talk about ROBO implementation specifically for postpartum hemorrhage because I don't have time to talk about all the disciplines that we use it in, but this has just been my experience with postpartum hemorrhage. So back in 2019, JCO came out with a statement saying that effective of July 2020, every hospital that was JCO accredited in the United States had to come up with some sort of way to reduce the morbidity and mortality associated with maternal hemorrhage. So when I saw this was just basically screaming Roboa without me even screaming it. It came to me. And so I took this to my OB colleagues who were well aware of the statement, and they were trying to obviously keep their JCO accreditation. But the key points to this statement are that, there needs to be a multidisciplinary program to come up with ways to mitigate mortality from maternal hemorrhage. They went by specific requirements and rationales and even added references to each statement. But it really said exactly what we are, what we use Roboa for trauma in. That's obviously to reduce hemorrhage and improve mortality. Our protocol at UCR, the OB department identifies the patient and then sends a group email out to all of our colleagues, L&D, NICU, anesthesia, in the operating room, trauma, and the trauma RNs. They're the ones that bring the MTP and also run the tags and bring the equipment. The SICU team, the blood bank. We schedule the C-section in the main operating room, trauma and OB as co-surgeons. 2 days before the patient comes to the hospital for the C-section, we meet as a group and discuss the case. The patient comes into the hospital and is admitted 1 day prior. The OB consent includes Roboa, so we explain to the patient what will be happening, and this is again the prophylactic use of Roboa. And then we follow our institutional guidelines for pre and intra and post-op procedures and patient management. So I'm not going to go through these in terrific detail, but this is just snapshots from our protocol. Basically talks about personnel required, a lot of people involved in this, so a lot of in-services, a lot of education, a lot of grand rounds. That's how this really all got started. We have other groups such as urology who are sometimes needed, and interventional radiology, and of course vascular surgery. We have a long list of equipment that everybody knows needs to be available for these cases. And then there's parts of the actual pre-procedure and the during the procedure and post-procedure that are actually done by the trauma surgeon, such as checking pulses, documenting pulses. And then there's other pre-procedural adjuncts that are performed by our colleagues as well. During the delivery, it goes step by step. The Roboa is inserted and inflated at zone 3. We check it by manual palpation through the C-section incision, and then the hysterectomy is performed, the balloon slowly deflated. So each of these steps are just painstakingly in detail, but this is what it took for us to develop our program and to get it to the point where we can all be familiar with what we're going to be encountering, not only during prophylactic use, but also in times of emergent use. So one thing we also have talked about during this conference is that aortic occlusion is occurring, right? So just because the balloon goes up and the blood pressure is normal, anesthesia is so thrilled, let's time to have a break, let's go for lunch. But obviously we have to keep reminding our colleagues that the aorta is occluded. And it got to the point where our OB colleagues were so happy and so calm that they were letting residents do these really difficult things that they would never have let them do in the face of massive hemorrhage, which is great for training, and we encourage that for training. But at the same time, we had to keep reminding them the aorta has a balloon in it. We need to keep going. I'm trying not to take away from training, but this is still a really critical time for this patient. So another interesting rationale for the JCO standardization was that there had to be an obstetric kit for hemorrhage located in IND, or located in L&D and also in the SICU. It also discussed basically an organization that practices skills. So what we had to do is every Friday for 6 months, we practiced our drill every single Friday. And then that way we developed an emergent postpartum hemorrhage plan that ended up working really well. So this is what we call our our overhead page. Is called Code OB MTPs. Everyone has their own, every hospital has their own overhead code. Some are colors, some are anything, but this one we decided was going to be Code OB MTP. And this is for the emergency 2 a.m. intra-op consultation in L&D. So it's a multidisciplinary response. The trauma team responds, the access is placed, and the patient may or may not get a REBOA. It depends what's happening and what can be done immediately. Massive transfusion, anesthesia, blood bank, and then the post-op ICU management. I touched on this earlier by the SICU, so it's also by us as well. We keep REBOA kits in the OR as well as L&D. And again, we did these drills for 6 months and really saw, anecdotally, have not published yet, but outcomes from these women is significantly improved. And the blood bank was thrilled because all of a sudden we had plenty of blood for our trauma patients as well. We were certainly saving those. So it allows time for help to arrive. Our particular group, the OB attendings, there were only 2 very, very senior partners, and the majority of the group were young faculty, like within 2 and 3 years of graduating from their OB training. So by the time they called their senior partners to arrive, an hour had gone by, and patients were hemorrhaging to death during that time. So we instituted this, and as soon as this starts to happen, the faculty know to call the trauma team in the middle of the night. We will come and help them. Meanwhile, they're calling their attending in to get a second pair of senior hands to assist with the procedure. And then, as I mentioned earlier, and don't want anyone to forget, we are enrolling patients that are suffering from postpartum hemorrhage in the AASD multi-institutional trial. Thank you.
So as usual, Megan, it's fascinating and wonderful work. And I would just share anecdotally that, it is, of course, every trauma surgeon's nightmare when you get that OB stat hemorrhage call. But I will say, because we developed a similar relationship with our OB colleagues, when I do walk into the room at 3 o'clock in the morning and there's panic, the panic tends to settle down, right? And the trauma surgeon, the trauma vascular surgeon is the person that's supposed to run into the fire, not run away. And I think our OB colleagues know that we're going to help them. So, and they feel better, and especially when they're waiting for those senior people to come in. How many times would you say you have actually implemented the protocol?
So we started doing this about 9 months ago. I've personally been called 3 times emergently since then, and have done 6 or 7 prophylactic scheduled elective cases. So I think it's going to become more and more common. And now I've moved to a different institution, so I'm going through the whole educating and in-service process again. But I think just like everything, it's just a question of education. And our OB colleagues didn't even know that this existed, right? We need to get into that realm and say, hey, we now have this available. We are here 24/7 to help you. Please let us know when there's trouble. But I am so impressed. Our OB colleagues are so grateful for us intra-op. They are just so incredibly grateful that we have this ability to help them and to help their patients like this. So I think education is really just the best way to get it out there.
And I bet your OB colleagues are very happy when Megan Brenner walks in the room. I know I would be. All right, thank you so much.
Thank you.
That's great.
So the next talk is going to be Pediatric Vascular Trauma, What Everyone Needs to Know by Dr. Goes.
Hello, everybody. Once again, I would like to thanks for the privilege of being here. And I want to send some hugs because I'm receiving WhatsApp messages from Brazil. They are watching the meeting and everybody is very happy. And including my mother, that is actually a doctor and she's watching. So
Hi, Mom.
Hi, Mom. A big kiss. It's the first time I could do that. Thanks, Fox. So in the next minutes, I will talk about pediatric vascular injuries. This is intended to be my first talk in the morning, but we had that little change. So this is the hospital I work at. My city is about 2 million inhabitants. We have no resources like endovascular things and helicopters capabilities to rescue. And we are now 10 vascular surgeons dedicated to trauma. This hospital works only for trauma cases. And when we are studying pediatric vascular trauma, the problem starts on defining what is pediatrics for trauma, because you have papers that limits that to 14, 16, 18 years old, sometimes are considered pediatric injuries. And the literature review also, it is unanimous that injuries are more common in boys than in girls. Some papers include iatrogenic injuries, others do not. Anyway, vascular injuries account for about 1% of all pediatric traumas. And the most common injury is the brachial artery. It's a traditional trauma mechanism for children that fall. And operating these small patients can bring big challenges, at least for me. And there are small vessels, you need to do stitch by stitch. They tend to spasm a lot. We don't have many materials. We should have, as you can see, we improvise, for example, intraosseous bone infusions for volume. And the most important, the low incidence of these cases make difficult to everyone to gain experience. Tip I can say is to use a size solution that mixes ringer, lidocaine, and heparin. It diminishes the spasm, reduces the spasm, and makes it a little bit easier. But no paper can prepare the surgeon to receive some cases. So this is a case of a carotid injury. This is not the picture of the actual patient, just use that to show where the injury is. So imagine that this patient came from a very special place called Marajó Island, and he took only 7 days to get to the hospital, the trauma hospital. He received initial treatment in a little hospital in the island, and then he gets with this zone 3 neck. He arrived with hemiplegia, neck through and brute. All the signs pointed to an arterial venous fistula that was demonstrated. This is the case, very difficult to get to this region by open surgery. If I had, I would certainly go to a carotid occlusion of course, trying to do a carotid test occlusion first, but we don't have it. So this patient waited to be transferred to another hospital. That's not a trauma hospital, and I lost, unfortunately, the follow-up. But I just want to demonstrate the kind of cases we have. This was a 9-year-old boy with an accidental mesogastric gunshot wound, a lot of associated vascular and non-vascular injuries. You can see vena cava injuries, superior mesenteric vein, pancreas, stomach, and small intestine. So the principles of damage control apply equally to children. As in this, also in this case, so a 13-year-old boy with injuries to the popliteal artery and vein arrived in shock. Tip is to use the larger caliber you can. Usually veins support a larger caliber, a larger diameter than the artery. This is a case of a motorcycle injury. The patient was wearing a cloth that was sucked to the wheel of the motorcycle and caused that. And the axillary artery was torn apart, and so the brachial plexus. And in this case, I open an exception and use the internal jugular and not the external jugular because the diameter was not sufficient, but it worked very well and the patient evolved very well also. And this is my last case, and it was a very terrible one. This patient, also an accidental gunshot wound. He found the weapon and accidentally shot himself. And he took about 8 hours to arrive in the hospital with this huge hemoperitoneum. And he had injuries to both superior mesenteric artery and vein, and was very unstable. So again, damage control. The only thing I could think about is to put a shunt in there. In these situations, I really think that the IV lines work better than other kind of catheters, improvised one, of course, because they are more flexible. And classical classical damage control shunts, and don't close the abdomen, and that's what we could do in these facilities. So this is a picture of my city. Thanks again for this amazing opportunity. For me, it's a lifetime opportunity. Thanks.
So that was a really remarkable experience, very tragic. What is the overall survival for these pediatric patients if they're coming from so far away?
We have published 2 papers. The title is Vascular Trauma in the Amazon, Updating the Challenge. So it's very difficult for us. About 50% of our patients need to travel more than 100 kilometers. And it's very difficult to compare apples and apples. So a popliteal injury, a femoral injury with an abdominal, a non-compressible injury. I don't know specific survival statistics for the pediatric cases. So anything I answer would be a guess, because we don't have this kind of registry.
Right.
I can tell you these 2 abdominal cases didn't went well, unfortunately. The axillary case went very nice. The other popliteal case we were also able to save. So that's it.
So the other question I have is there's a lot of literature talking about pediatric catheterizations using the common femoral artery in children with heart defects, and it shows they end up with a limb length discrepancy as they grow. Have you seen any of this in your population?
I haven't seen personally, but I can tell that recently I made a literature review for a chapter I wrote in a textbook. And the nowadays evidence suggests, for example, there is a terminology that I wasn't aware, called pink pulseless hand, which defines the hand that has no pulse but is not threatened. So nowadays, the evidence support that you don't need to revascularize this limb, and most of these children will evolve without sequelae.
Do you have any specialized instruments, small instruments that you keep for these kinds of emergencies?
Not at the vascular tray, but at the ophthalmologist tray and the hand surgery tray, and we get that and use those, and works very well.
Yeah, that's brilliant.
Perfect.
All right.
Thank you.
Thank you.
Okay, thanks.
And our last, I believe our last speaker of the day before we hear from Dr. Fox to send us home is Dr. Junichi Matsumoto. And Dr. Matsumoto is going to be speaking to us about the significance of the chief imaging analyst in EVTM. Dr. Matsumoto.
Thank you very much. I'd like to talk about, I'd like to share significance of imaging and imaging analyst, I mean, a radiologist. I'm a very radiologist, but belonging to emergency department, not radiology department, and doing a section chief of emergency and trauma radiology in university hospital. Okay. And imaging information will guide you to make appropriate treatment strategies. If you want to do good treatment, you need to make a good plan. And imaging information is one of the great information resource resources. And to utilize that, you do need to understand the essentials of imaging utilization, but you do not have to be a radiologist, I think. And I'd like to share the essentials today. And one is the extremely quick CT examination. The second is appropriate evaluation method of images, and 7 key points in imaging analysis. You need to have time-conscious CT protocol, like CT room stay time within 3 minutes, not CT examination time, CT room stay time. This is the movie from the training, monthly training in our institute, and with using 80 kilograms phantom doll. And once we set the patient in the CT gantry, we start, the CT is already on, and we start scanning of non-contrast head and neck with giving contrast, and finish the non-contrast CT before the contrast comes to the head. And we do not obtain planning scan in this protocol. And after 20 seconds, we do arterial phase, and we need to wait for 60 seconds for delayed phase. And to do this, you have to prepare things like organizing tangled tube and lines, and pick appropriate line for contrast injection. And you need to remove unnecessary metallic objects. And if possible, you need to fix hands and legs during primary survey. And once you finish the examination, and you take the patient out of the scanner. And in this protocol, this time, the CT room stay time is 2 minutes and 53 seconds. This is the sub-3 CT examination protocol. And to do this, you need to have a team effort. And you also need to have appropriate imaging evaluation method. And we have suggested 3-step reading method. And now it is published in Japanese guideline. And the first step is focused 3-minute assessment, which is called FACT, focused assessment with CT for trauma. And the second step is immediate consecutive secondary reading for treatment strategies, followed by immediately after the FACT. And in tertiary survey, we do thorough head-to-toe checkup. But this can be done after admission or after initial treatment. So important thing is first and second step. And this is the, in fact, predetermined pathologies and sites are evaluated. And this should be done within 3 minutes. And ideally, you have to finish this process while the patient's still in CT room. And you can, ideally, it's better to make rough treatment strategies during this FACT. And you can, imaging analyst can say, oh, you need to take the patient, go to the OR or go to the angio suite, or just go back to the ER. You can make rough strategies according to the result of FACT. And in the second reading step, we have 7 key points. And that is mechanism of injury, time passed from the event, and hematoma size, IBC diameter, active bleeding, bleeding space, and anatomical variations. Knowing mechanism of injury predicts possible injuries, enabling you to detect earlier and prevent overlook. And time from injury is very important, because to know time from injury to CT will allow us to understand the significance of imaging findings in that patient. For example, medium-sized hematoma in 30 minutes means much, but a small hematoma in 90 minutes means less. And the hematoma size is suggests severity of and urgency of bleeding to that patient. So it is important to know the size of hematoma. And IBC diameter indicates the balance between lost blood and given fluid at that time of CT. Small IBC suggests fluid resuscitation is inadequate, even if hemodynamics appear stable. In these pictures, you see on the left, this is arterial phase, and on the right, delayed phase. You see the size of IBC is getting larger with IB contrast. So this is IB contrast responder. But in the lower pictures, you see the diameter of IBCs stays small. So it means IB contrast non-responder. So it means you need to give more fluid or you need to hurry. And it is very important to find active bleeding, of course, and when considering treatment indications. And of course, extravasation is much more dangerous than pseudoaneurysm. And when considering the degree of urgency and treatment priorities in polytrauma, it is also necessary to consider where active bleeding occurs. Where is, like a free space, loose space, or tight space. Examples of free space is like peritoneal and pleural cavities, and loose space, retroperitoneal cavity, or mediastinum or splenic parenchyma without capsular disruption. And tight space is like intramuscular or liver and kidney parenchyma without capsular disruption. With capsular disruption, you have to think those as loose or free space bleeding. In this case, you see mediastinum and retroperitoneal extravasation. Those are thought to be bleeding in loose space, but on the left lower corner, you see very bad extravasation from the lung into free pleural cavity, resulting in a large amount of hemothorax. So this is the most dangerous hematoma in this patient. And the final thing is anatomical variations. Understanding vascular anatomy is very important when considering indication for endovascular treatment. So CTE information is very essential to develop good treatment strategies. And you don't have to be a radiologist, but you do need to understand essentials of imaging utilization. And during whole process of treatment, you have to assign someone as Chief Imaging Analyst, CIA. And CIA should appear from the very beginning, waiting for the patient together with clinical team and get involved from the beginning. And then you have CIA read portable x-rays. And even after CT examination, you read cases right next to the patient with clinical team. And during angio and during surgical operation, CIA is always be with the clinical team right next to the patient and giving information about imaging. So with CIA, you can provide better or appropriate treatment, and that can be faster, safer, more confident, and less invasive with avoiding waste of time. And with hybrid ER system, I think the role of CIA is getting more important. Thank you for your attention.
So two things, Dr. Matsumoto. That was a wonderful presentation. The first thing that we were struck by is the speed, and there's something that you're doing that we somehow can't do, because you do the entire scan in the time that it takes for my technologist to just enter the patient into the machine. So there's something about, I'm going to use the word protocol. There's something about what the GM or what they're doing at my place and maybe other places with the mouse, with the computer mouse, that takes a very, very long time before they start the scan. And you seem to have been able to skip that step and start the scan much faster. How do you do that?
If you scan a patient for planning which area you scan, so then you need to use mouse and you need to set the range of scanning. But we put the patient on the certain position on the CT table. Then you can set the right range of the scanning. So you do not have to set the range of scanning. So you can skip that process.
Something about the position of the patient on the gantry.
Yes.
Right.
May
And
I
then-
comment on this?
So,
We
please.
adopted the Japanese protocol. I think the majority are having the same problem with the scanogram and how you plan your CT. It takes a long time. 90% of the people will be able to be scanned in one scanogram. They're doing a very interesting protocol. You put the contrast, you do the head and neck, and the contrast come. You continue 60 seconds, you get the Venus stage, which is essential. We managed to do it. We're not perfect on this. We got the critic that we're doing it in the price of a lot of radiation. So now in Sweden, we are highest in radiation in trauma patient. So it's a price to pay. So we didn't get to this level, but the time of CT done correctly, it's not always there, but it's extremely fast. It's a minute. I would say around 10 minutes of planning that you get crazy. You see the mouse, you get crazy, and you don't understand what the technician doing his work. But it's a quite a fascinating protocol with the price to pay, I guess, with the radiation.
The radiation dose goes to double, maybe. But if you do follow-up examination, something, so you scan the patient, but now we are talking about very severe patient. So you do not have to worry about the cancer from radiation, but you need to, time is life now. So that's why we need to apply the protocol.
Second question was about the CIA. So I'm hoping that I can, so United States, it's a secret agent, So I'm hoping maybe we can borrow you as to be our secret agent. But seriously, so for me in my place, we have a radiology residency, a training program. And there is a radiology resident. It's usually a slightly upper level resident that's assigned to the emergency room. And with somewhat reluctance, they sometimes don't want to be the CIA. We do get them to come to the scanner and do a wet read. And then the trauma surgeon or the chief resident will go into the reading room with their better reader and go with them. I do think it's absolutely essential. Trauma surgeons, vascular surgeons think they can read their own scans, but when you're sitting there, this is what you do for a living. This is your job. You notice a lot of things that we don't notice. So I would encourage the audience to get themselves a secret agent.
A technical question. Do you think that this protocol is feasible with every kind of CT, 64, 128, or is necessary a double phases? What do you think?
You need to pick right patient. I mean, the most severe, very unstable patient, we do that CT protocol. But the stable patient, we discuss. What do you want to know? So it depends on the patient. The machine is 80 slice MDCT.
Who makes it?
Canon.
Canon.
Yeah.
Right. We got
But
Canon.
we have 320 slice MDCT also, but in emergency center we have 80 slice. But it's not the high end machine. It's not the high end.
Dr. Matsumoto, when my radiology chair says no to me about this, can I call? I'm going to call you. Is that all right? I'll get your email because I know they're going to say no for whatever the reason.
I have one question. I have a significant interest in volume responsiveness of veins, especially deep veins. And so you're saying that you're looking at the cross-sectional area of the inferior vena cava as an indicator of ongoing hemorrhage or volume responsiveness. Are you looking at this at a specific region? Is it always at the diaphragmatic hiatus? Is it somewhere else? Because
that's a very good question.
In people with compressions, you're going to see variability.
Yeah. We look at the level of 2-3 slice above the renal vein union, 2 slice above the level.
Okay.
And but if the IVC stays small, like a lightning cable, so it's very dangerous. Even you cannot see any extravasation or bleeding in the body, you may have something out of the range of the scan. So it is very easy to know how much, how danger you are in your situation is.
What is the volume of contrast you're giving?
About 100 to 150 cc.
Okay.
With the rate like 3 to 4 cc per seconds.
Gotcha.
Megan?
Gina, I just want to say you would make your mentor, Dr. Shan, very proud. There's something that you show in here that you don't highlight because it's normal for you, but it's very abnormal here. And that's that the radiologist is standing next to the patient, which never happens. They're not even in the same floor. They're not even sometimes in the same building or even in the same country. So what you're doing, I think, is something that we all need to try and encourage, even if it's just with the trainees, with the radiology residents to come in so that they can actually see the trauma patient instead of, trying to look for the history and epic and never finding it. And I think that would actually cut down time to getting some reads on some films too. But I think having the radiologist next to the patient is critical. So thank you for that.
In Japan, how many radiologists here? Okay. In Japan, generally speaking, radiologists are not passionate about trauma or emergency thing. They like to be in the dark reading room. And so we need to encourage them, but it is very hard to get good radiologists from the reading room. So now we are trying to get candidate from emergency physician or trauma surgeons. So if we train them, they can become very good imaging analysts. So in our institute, so far we have trained 30 emergency physicians, and 10 became radiologists. 10 went back to emergency, and 10 is under training. So the good farm is for us is emergency doctors.
Wonderful.
All right, thank you so much. Dr. Fox, send us home.
Well, Tal, I'm losing count on how many EVTM meetings we've had now. But thank you for your inspiration and enthusiasm and wanting to bring your meeting to the USA. And thank you all for attending and participating, the faculty, the speakers, and all the support that we got. On behalf of Dr. Scalia and Kundi and myself, we wish you safe travels back. Please send me an email. Let us know how we can do better. This has been the largest attended meeting in the US now. We can continue to grow our membership, and just send me a small note when you got time just to let us know what you think. Thank you.
Do you have, can I take your email? Because I know when I go home and I tell them that they don't have to do all the mouse, and this is you. Yes. Here. Beautiful job, by the way. Very nicely done. Thank you.
That was wonderful. Thank you.
Are you heading home soon?
Tomorrow,
All the way straight back to Saint, what was the name of that?
St. Mariana's.
Going all the way back? There's a nonstop from?
Yeah, direct flight from Dallas.
Oh, from Dallas.
Yeah.
Oh, so you have to fly first to Dallas.
To Dallas.
No.
Oh, Dallas.
DC.
I'm sorry. DC. Yes, yes.
Yeah.
How long a flight is that?
14 hours.
Wow. You're going business class, I hope?
No.
No, they don't let us go business class either. I wish you a wonderful, safe flight home.
Thank you.
So nice to meet you, sir.
Wonderful.
Thank you very much.
The comment came out a little bit wrong there. It's not like I've been coming for surgery. Oh my God.
Sure.
Senior residents again. Look at Dr. Scalia, ready for 70 now? And he's taking quality night still.
Yeah, he's unique. Now that is not where I'm going to be.
He
When
was
I'm
62 when I was. I would like to call this Scalia, and you have
crazy.
crazy.
Yes.
But having you there like before, I don't know, yeah.
Yeah, that's true. And also it's a problem because the training now is so much shorter. Don, it was very nice to meet you. Go ahead. Yes.
I just want to do it and
Yes.
get it out.
Yeah, You all feel that way. No. Yeah, that's just the way it is.
When are you going home? Straight home?